We've had two really good presentations, both about gallium-68, which is coming to Stanford very soon, and the lutate trial, which just started enrolling patients here. I wanted to see how we're doing just in general knowledge before my talk starts. So if you have a cell phone and are willing to text to 22333, I'd like you, if you have an idea of the number of centers that offer gallium-68 PET CTs in the world. Are there under 15, 15 to 30, 30 to 45, or over 45? So if you take out your cell phone and just text this number, those particular numbers, to 2233. We've got a couple votes in. See how we're doing? What? This is in the world. How many centers that offer gallium-68 PET CTs in the world? Okay. I'm going to let it go for about 5 more seconds. All right. So we're pretty much in the, we're getting people in there. It's exciting. This is real time. Anyone from around the world can do that. So the general consensus is that there's under 15. Let's see if this works correctly. All right. Gallium-68 PET CTs are only used for patients with NETs or carcinoid. Again, if you believe that's true, or you think that's true based on what you've learned, or I'll let that go for a little bit too. And we didn't really talk about that, so I can completely understand. Not just PET CT, but gallium-68. You guys are much better than I am. I would have never guessed that. Okay, the next question for today. Total amount that the US government funds for nuclear medicine research. I'm going to give you an interesting thing, is that this isn't from the NIH. It's actually from the Department of Energy, because it used to be under the Atomic Energy Commission. So again, those are your choices to go to 22333. Do they give no money? Do they give over 75 million? Do they give somewhere in between? It says I get total results 28, but I don't see any of the results, which is too bad. Let's see. I'll pull up that in 1 second and see what it shows us. And the last question was, how long ago or when did clinical trials for PRRT start in the United States? Just this year, the last 5 years, 5 to 10 years ago, or over a decade? That's clinical trials for PRRT in the US. Very cool. All right, and now just so you know, I bought the free version, or I didn't buy the free version, so I max out at 40, but clearly you guys were very excited about answering this one. Well, so during this talk, I hope that I can answer a lot of those questions, and at least it will stick in. My talk is already up on the norcalcarcinet.org site. You can see it under the CFCF, and as many of you guys know, I like being a little different. So if this all works, I'll start you on a different tour. Pam asked me, and thank you, Pam, thank you, Ron, for inviting me, to actually talk a little bit about what a patient goes through, or my story a little bit, and then a little bit about what I've been working on. And I realized that I couldn't do them in an easy slide where I could separate them, because in fact they've been intertwined as a story or as a thread. And the thread has actually taken me around the world. I'm kind of amazed at the number of places I've been. Patient perspective on molecular imaging, I have no disclosures. Our objective is to learn more about gallium-68 and PRRT from a patient perspective and better understand the challenges of making both of these more widely available in the US. It starts with a diagnosis. Everyone here has one, okay? For many, it's easier said than done. I know many of you have struggled for decades or at least 5 or 10 years to get a diagnosis done. My case wasn't so bad. I was a blind pickup. I was picked up by my internist. I was picked up kind of huge, to be honest, in very advanced state of the disease. So I had no symptoms, just came in for my annual exam. Once diagnosed, you have many options. Dr. Fisher went through that whole chart of what you go through. Surgery, ablation, octreotide, newer drugs. Some people call it observation or wait and see, and that gets a really bad rap. I like to say wait and learn or watchful learning. There's a lot you can do while you're trying to understand what's going on with the disease. So I don't like the use of wait and see. I like wait and learning. For me, I use that time to educate myself. It's great seeing 250 people in a room. When I was diagnosed, there wasn't a conference that was coming up. Matter of fact, for about 7 months after my diagnosis, I didn't meet anyone else who had this. I didn't know anyone who had this. All the doctors that I had met, other than my oncologist, had talked about seeing it only in their textbook. So I wanted to find someone like me. I lucked into going to the cancer support community in Walnut Creek, and as I was doing my intake, there was this little thing that said there was a carcinoid neuroendocrine support group, and I wandered in. And, sorry. That really did change my life. With that, I learned people who, I was with people who taught me to be educated, to go seek out things, and to learn all I could about this disease. And the first conference that came up after I was diagnosed, oddly, was in Toronto. And actually, who went to the Toronto conference? I know one group of people. Yes, a few of us are in here. And it was a great conference put up by CNET. It was 3 days. Maureen Coleman, who was the leader of CNET's Canada, is no longer with us, was a great and gracious chair for that. For me, my options were limited. I had very large disease. I couldn't be operated on. I talk about tools in a tool chest, and George talked about 2 more tools that have been added recently. I didn't have those tools. Those tools weren't around yet. And so for the conference, all I heard a lot was octreotide therapy, which I wasn't on, surgery, which I couldn't have. Had 2.5 days of it before this professor from Germany came up and started talking about, I don't know what you're treating if you don't know, if you can't see it, or what it is. I really think you should be able to visualize this a little bit better. And there were charts that went up, let's see if I get the pointer right. No, well, yeah, I do. That talk about how much more sensitive, or the sensitivity, the specificity, and the accuracy of a PET-CT with gallium-68 versus a CT or a SPECT or as we know it, as an Artria scan. I'm a technologist, or I used to be a technologist before I ran into all these people in nuclear medicine. Now I'm just a guy who was an entrepreneur in Silicon Valley. A technologist is the guy who takes care of, or the woman who takes care of you on the way to getting the scan. But I like data, and I went, I need more data because I'm unresolved. I need some answers. I was also buoyed by the fact that a lot of people go elsewhere to seek treatment or advice. So that got me on a plane to Bad Berka, to where Dr. Richard Baum practices, who had given that presentation. I will say that started a lot of what I'm doing now. I got a Word document that said, here's how to get to the clinic, go have a good day. First of all, for all of those of you who heard the word clinic and think of 4 bedrooms or 4 little suites in the back room, that is the 800-bed clinic that we're talking about. It is quite a large facility in Germany. I had a gallium-68 scan in December of 2008. It showed what will happen for most of you who do this, no difference, okay? For about 50% of it, it will not add any information. This is an important thing to know so that you're not disappointed when you go do this. It is a great scan, but it is not the best scan in the world, and it won't show things that aren't there. And if the Octrio scan imaged it correctly and the CT imaged it correctly, it won't show any more information. Okay? I had a gallium-68 scan in a place that does 700 a year, that treats nearly 1,000 patients for PRRT, and I was told not to have PRRT. Kind of surprising, because we've heard how safe and all the things. I had massive disease, but he said, you have stable disease, you have high quality of life. These are options that you need to take when it's time to take them, but all substances are poison. There is none which is not a poison. The right dose differentiates poison and a remedy. Don't take your poison before you need to. The other one, which Pam and I were talking about a little bit earlier, was the right care, the right patient, and the right time. And as Pam reminded me, with the right evidence. A lot of you have talked to me about PRT over the years. I did this little travel site because I realized people can't get from a train station to a clinic, get afraid of traveling overseas to do things. I got a lot of email. I got so much with how to do, what, can you tell us more about PRT, or we want to do more, that we created prtinfo.org. This is the site for those of you who've seen it. I was surprised. I thought I'd actually release this and 50 people a year would see it. Maybe a couple hundred would have a spike. At this point, it's actually now 1,600 unique visitors every month. I'm surprised by the number of caregivers that actually use the site to send it to their family to let them know what they're having might be okay for them and it's not this far out radical idea. These are some of the things that are searched on the site and what we keep track of and how we put articles on the site. I will say my education increased because after 3 rounds of PRT treatment, I did end up having symptoms. After 18 months, I did actually, let's see if I can go backwards. I apologize for that since I'm giving this from a patient's perspective. I should say a little bit about. So I am an N of 1 and evidence-based. In other words, you need to look at all the tools in your toolkit and not just take a look at what may have happened to me as a thing to say PRT is great. It is a toxic, there's a lot of things that can go wrong, and I've certainly talked to people who have had treatments and who haven't done as well and who have had toxicity to it. But I have had Y90, which reduced my octreotide use by 2/3. I'm a VIPoma, for those of you who don't know. I had 2 things that aren't even under trial. In reality, I had something called Tandem, which is Y90 with LU-177 twice. I'm off octreotide. I'm going back for my, 4th year staging at this point. This will be my 8th gallium-68 scan. In 2003, and as I started working on this, it was, why am I going to Germany to get scanned and to get treated? I'd love to come here and get scanned and get treated. And this was my start on this. I was invited to come to the first World Congress of Gallium-68 and peptide receptor therapy. I'm trying to cram in what might be 6 days worth of presentations, over 2 of them now, into the remaining 4 minutes. I was one of 5 patients and 400 medical professionals. Do you get the gravity of that? There were 400 professionals, of which only 4 of them anyone in this room would know. The number of people who are working on nets that aren't people that you know, Pam, George, Emily, Eric, are staggering. I met so many people I had never had any idea were involved with neuroendocrine care and cared so deeply about it. I think that was one, as a patient, which warmed my heart. Ajit, who ran Singapore nuclear medicine and pretty much nuclear medicine for the rest of the developing world, unfortunately, he passed away this year, and that's why I keep his picture up there. Michael Schultz, he is actually kind of one of the brains at University of Iowa in their radiopharmaceutical lab. Dr. Tom Odorizio was there presenting a paper about Y90 clinical trials that were done in the US in the early 2000s, right? I thought we didn't do Y90, or we didn't do PRRT, we didn't do Y90. Here were the reported papers of early trials that done in the US. Eric Liu. I'm going to work here. We talked about why from a patient perspective this is interesting. The resolution, the gallium-68, much greater. I won't talk about binding affinity. I had a small child, I still do. He's now 7. He was 8 months at the time. When I had my Octria scan, my wife was also having trigger release surgery. I couldn't go home, she couldn't hold the baby. We had to have someone come there because that one day that I needed to have the scan was the same day that she had trigger release surgery. Look at the dose radiation between the two, taking a lot more radiation in with the Octria scan. Andre showed you the generator that would fit. Andre, how much room would you need for the generator? Can you kind of give them an idea?
1/4 of your box.
1/4 of the box for the generator. How much room would you need for a cyclotron?
1/4 of the room.
1/4 of the room, and several $1 million more. The beauty of gallium is that it's produced, and actually there's a term for it. The generator is actually known as a cow. So if you're in the business, it's a cow. What they do is milk the cow to get the dose that you're going to be scanned with. So they go milking every morning so you can have a scan. Convenience, 2-day procedure, 3 visits versus a 90-minute procedure, 1 visit. What happened out of that? There we go. So much more than just for nets. I'll show you later where all the peptides can be used. PRRT we use, everyone thinks of it as a pill, a single idea. It is not. It describes a whole set of possibilities, peptides, isotopes, delivery methods. We talked about 2, lutetium and lutetium-177 and Y90, but there are more, there are some alpha emitters as well. That's actually gallium. It melts in your hand. You can buy it at Amazon. It is actually $65 per 100 grams. That's not the stuff they put in you, though. They actually use germanium to cut it down. Vanderbilt started its IND right after that conference. I'm actually showing you the results of it because one of the things when I came back and would have talks with George, Dr. Fisher, or I'll call you George, and Emily is like, and Dr. Waltering is, we know that it's interesting, but does it change? Really, do we have evidence that it changes? And a lot of the first studies that were done in the US were not only on safety, but does it change outcomes? This is Vanderbilt's results. This was published actually on the PRT info site. This was actually from the Vancouver meeting where we're talking about how we're going to go this forward. This is their results from their first 80 patients over 2 years. It changed restaging 57%, diagnosis 11%. The amazing thing to me in here is the number of candidates for PRT went up 20%. I questioned that in committee. I said, I'm a member of the gallium-68 working group, and I said, I don't think that's an accurate slide. It's not, we shouldn't present it. And I got on the phone with Dr. Liu, and I said, you know, this is probably someone who was just a little Octria scan positive, and you know, you decided they were more, said no, these were people who were O-scan negative, who were gallium-68 positive in his study, and they did not have an option of PRT before, and now it became their best option. It changed. This is the University of Iowa study, which, interesting, they had slightly different results. They thought they would find people who had this unknown disease and would use it for diagnosis. They didn't really find that. Turned out to be a really bad marker for people who had symptoms. Turned out that it was really good for them to find primary tumors in people who had unknown primaries. Believe it or not, I was in India earlier this year, presenting a little bit about patient education in gallium-68 and PRRT. And there again, I learned a little bit more. For me, one of my biggest worries in seeing all this gallium stuff is I was worried it was only 4 nets. And there wouldn't be enough funding, and there wouldn't be enough places going forward to do this because there wouldn't be enough momentum. In India, we learned that gallium-68 is using a lot of different peptides to start doing things like HER2-positive breast cancer, metastatic prostate cancer, lymphoma, as well as some other diseases and other things that are they're looking forward here. Pretty exciting stuff. It means that this will go for the long term. There was Eric brought up the fact that you can go home after a lutate treatment. One of my big questions, and we had a paper from Perth presented, that shows just how real that is, because I was getting requests from some patients that were in Basel who were actually keeping hotel rooms, 2 separate hotel rooms, one for a wife and one for a husband, and they wouldn't eat meals in the same room at the same time for an entire week. So this is actually the scatter curve of how much exposure rate you still have in you after therapy in hours. The red line being what's actually safe in Australia, and you can see that most everyone is in the safe level after 5 hours. This is lutetium, it's not Y90, they're different, they have different half-lives, it will change. But this gives you an idea. This was a study that was presented there. Here's the world map. So those of you who are under 15, we're actually over 45. These are the places commercially you can get gallium-68. The places that I was trying to add that dot for Andre before this meeting started, but I keep this chart updated on how many places in the world you can actually get gallium-68. Why? Well, in places that use a cyclotron to use for nets, they may not be able to afford a cyclotron, they may not be able to ship it in. You got gallium, and you can actually, be careful, it's gallium-68. Always been able to get a gallium-67 scan in the US. It will do you no good but give you about 4 times the dose of radiation that an Octria scan will. So don't go back asking for a gallium-67. I know at least 3 people in the US who after a conference have done that. Don't do that. Not a really good idea. But this is where the map is now, and the generator, as Andre pointed out, the startup cost is $100,000. It's not too bad when you consider a cyclotron will be a couple $1,000,000 and a good, nice cement pad to put it, and a whole lot more work to get it to go. So you can see that we can have things all over the world for gallium. Okay, so why not here? Okay, what we've seen so far is INDs. That is something that allows Andre or these different centers to run safety tests, to run some clinical questions, but not NDAs, not a new drug application. George has talked about this earlier. You know, there are patents all over the place. I've actually listed when the patents are expiring for certain things, and one of the nice things to know is that the patents are expiring on a lot of this in 2015. But there are no deep pockets to fund this. No one's coming forward and saying, I'm going to have a clinical trial and give a couple $1 million and be able to run my clinical trials. Government funds, as I talked about, are really, actually I haven't talked about. It's the total number that the DOE gives to fund nuclear medicine research is $5 million. That's up from 0. We were at 0 in 2007 and down from $30 million at the beginning of the century. So if you think about where this is going to come, that people are going to fund this type of research that they're doing, it comes from us, it comes from societies, and the Society of Nuclear Medicine, which Andre talked about, will help, and I'll talk about that in 1 second. One other thing that we don't talk about is reimbursement. PET CTs are bundled. In other words, when you get a PET and there's an imaging agent, that's all included in what Medicare pays. As Andre pointed out, and as some of the stuff on PRT info is, I'll be fast, is it takes a little bit, they will not fund that extra peptide. They just bundle it in the regular PET. So in Vancouver, the Society of Nuclear Medicine came through with a gallium-68 working group, which took 20 phone calls, 6 face-to-face meetings, lots of drafting sessions, a 48-page PowerPoint, which is available at prtinfo.org as well, if you really want to read it. A 20-page imaging manual, which actually I contributed in with how much or when, how long people can be on octreotide therapy prior to being imaged, and one poster. And the poster was presented at NANETS last week and is outside discussing our pathway. Our pathway is actually, as Andre pointed out, the society stepped in. They have a clinical trials network. What we're going to do as part of the Gallium-68 working group and the clinical trials network is we're going to let these NDAs, we've harmonized them with this imaging manual. We're collecting the same data, and the clinical trial network will apply for an orphan drug status for Gallium-68, run a clinical trial when the patents are nearly out, and then actually release it to the public domain. There's still more to do. This just isn't, there's a lot to do with PRT. This week I was visiting with Homeland Security, and to try for patients when you come back, you're radioactive. Homeland Security seems to have an issue with this. I don't know what their problem is. Those of you who've gone through it, we can talk about that later. Tuesday we were talking on the Hill, and if you ever do go to the Hill or talk to your congressperson, tell them not to take money away from nuclear medicine. They don't get much. We need what we can get. We also need to make sure that scans don't get cut any farther. I know I talked a little bit past my time, but hopefully that was interesting.